Our aim is to provide best education and awareness program about fatty liver disease to healthcare professionals, patients, and their families. Today, we are honored to have Dr. Dhruv Kant Mishra, a renowned gastroenterologist from Delhi, as a guest speaker. With several years of experience in the field, Sir is known to provide exceptional care to his patients, and spreading awareness about MASLD is truly commendable. We are grateful for his dedication to improving liver health. So, without further delay, I would like to invite Dr. Dhruv to share his valuable insights on current perspective on MASLD and MASH. Over to you, sir.
Thank you so much, ma'am. Thank you for the kind invite. I'll get to it immediately. So today we'll be talking about current perspectives in MASLD and MASH, which is metabolic associated steatotic liver disease and steatohepatitis. So when we talk of the liver, we find that the liver is the second largest organ of the human body, and it is located in the upper right part of the abdominal cavity. It is on top of the stomach and the intestines. It is usually pinkish brown in color, is very soft, and it is highly vascular. That is, it has a lot of blood inside it. The liver has a lot of functions. It processes nutrients, it regulates our blood composition, destroys old cells, detoxes our blood, produces bile, produces proteins, cholesterol, breakdowns alcohol and all the medications that we take. And it also controls around 500 metabolic processes running simultaneously within the body. So MASLD, which was initially called MAFLD, is a condition in which fat makes up more than 5% of the total weight of the liver, and this should not be caused by alcohol use. So if left untreated, MASLD can progress further and become a condition called MASH, which is metabolic associated steatohepatitis. So what are the risk factors? So if you're overweight, if you're obese, if you have diabetes or very high cholesterol, then you are definitely at an increased risk for MASLD. How prevalent is it? How common is it? So 1 out of 4 people in this country have MASLD irrespective of their weight. Even in thin people, we see a lot of fatty liver. Whereas the numbers are starkly high in those who are diabetics or obese. So more than 6 and 9 respectively of diabetics and obese people out of 10 have MASLD. That is, 9 out of 10 obese people will have fatty liver. The male gender has been regarded also as a risk factor for progression to MASH and fibrosis. That is, males are at a higher risk of developing cirrhosis of liver because of fat. How does it progress? We first have a healthy liver, then deposition of fat, which causes a fatty liver. Then it causes hardening of the liver, which is called fibrosis, and eventually progresses to cirrhosis, where there is scar tissue formation, which destroys the liver cells, and the liver is unable to work properly. What is the difference between MASLD and MASH? So steatosis, simple MASLD is simple fat accumulation within the liver, whereas MASH is the accumulation of fat plus inflammation and scarring. What are the causes of MASLD? Most common, again, like we discussed, obesity, diabetes, metabolic syndrome, certain medications, the type of food that we intake, and physical inactivity. How does obesity and fatty liver disease worsen our problem? Being overweight or obese causes fat to accumulate in the liver. This obesity increases the amount of fat to around 5 to 10%, and this leads to MASH and scarring of the liver. The association between MASLD and diabetes is bidirectional. That is, those who have diabetes have a threefold higher risk of MASLD and vice versa. Also, there is a threefold increased risk of death due to cirrhosis of the liver in diabetics. In those who already have fatty liver, there is a 2 to 4-fold increased risk of developing diabetes. What are the symptoms of a fatty liver? So the symptoms are usually vague and non-specific. We have abdominal pain, weight loss, loss of appetite, enlarged blood vessels, nausea, jaundice, and in extreme cases, we can have an enlarged spleen, red colored palms, extreme fatigue, as well as confusion and trouble concentrating. How is fatty liver diagnosed? Fatty liver is usually a silent killer because progression of the disease is very gradual and also very silent. It is diagnosed by some blood tests, by ultrasound or a process called as fibroscan. The gold standard still remains to be a liver biopsy, wherein a needle is taken into the liver and some liver tissue is removed to be examined. And X-ray, CT, and MRI also help us in the diagnosis. Most common blood tests are SGPT or SGOT, also known as ALT, AST, and persistently elevated ALT, that is high SGPT, is associated with disease progression. Patients who have normal LFTs, patients who have a normal SGPT, can also have fatty liver disease. Even up to 80% of patients with fatty liver can have a normal ALT. And there is no designated cutoff. There is no absolute value which can tell us whether there is fat, whether there is fibrosis. These are just rough numbers which can help us guide in the diagnosis. Various scoring methods are also established, and these scoring methods have been established to diagnose more better than simple AST or ALT. Online tools are very, very easily available, very commonly available, easy to do by non-medicals also, and they are available to calculate these scores. Once we calculate these scores, a score is generated which helps us understand how much at risk we are of fatty liver and how bad is the fatty liver. So the non-invasive diagnosis, that is, we do not do anything invasive, no invasive procedure is done. These are usually done by ultrasound, which can give us a rough idea of how much fat there is in the liver. But the problem is that it detects fat only if fat is more than 25%. And ultrasound cannot differentiate between fat and fibrosis. Transient elastography, more commonly known by its brand name FibroScan, is an excellent test. It helps us diagnose fat if fat is more than 10%, and it can help us differentiate between fat and fibrosis both. It is easy to operate, but in obese people, it can give us a false value. So, transient elastography, like we discussed, it tells us two different things. It tells us how much fat there is in the liver and how hard the liver is. That is the degree of fibrosis in the liver. Other methods for non-invasive diagnosis include an MRI PDFF, which is a proton density fat fraction. It is an MRI of the liver, which tells us exactly how much fat there is in the liver, and it can measure fat content even up to the level of 1%. Invasive tests, which is the liver biopsy, which is currently the gold standard for measuring the amount of fat in the liver, the amount of fibrosis in the liver, and the damage that the fat has done. It is the only method to truly diagnose MASH, that is cirrhosis. But it is painful, it is individual dependent, and in early stages, it can lead to a misdiagnosis also. So, progression of the fatty liver to cirrhosis takes years, and the key is early intervention. So, in the early years, there is none to very minimal progression to fibrosis and no increased risk of death compared to the general population. However, once MASH has set in, these numbers change rapidly and significantly, and there is increased risk of death due to cardiovascular malignancy and liver related issues. And again, the fibrosis progresses rapidly when associated with diabetes, insulin resistance, weight gain, and worsening LFTs. So we must remember to act before it's too late. Metabolic dysfunction associated with steatohepatitis is a more serious form of fatty liver in which there is scarring of the liver. This can lead to cirrhosis or even liver cancer. What is the treatment? The treatment is relatively simple. There is a particular diet that you should take, some exercise which we'll discuss, lifestyle modifications, and new medications. Most important is controlling your weight. So, a combination of a calorie less diet, a hypocaloric diet, and moderate intensity exercise provide best likelihood of a weight loss. Weight loss of at least 3 to 5% body weight helps to reduce the amount of fat in the liver, and a weight loss of 7 to 10% improves even the biopsy features. That is, the histopathological diagnosis of MASH also improves. What is the weight loss effect? If the weight loss is around 3%, steatosis goes down. If weight loss is more than 5%, the histological parameters start improving. And if the weight loss is more than 10%, then fibrosis, that is hardening of the liver, goes down drastically. What is the diet that we should be taking? So this is called a Mediterranean diet, which is relatively easy to follow. We should have moderate portions of eggs, cheese, yogurt, and poultry. And every day, each meal should be based around vegetables, fruits, whole wheat grains, preferably made in olive oil with beans, legumes, and seeds. Red meats, sweets, and high carbohydrate food, rice, potatoes, should be avoided. And seafood and fish should be taken on a 2 to 3 days per week basis, not more than that. When we talk of exercises in fatty liver, it is of two types. There is aerobic exercise, which reduces liver fat and improves cardiovascular conditioning. Aerobic exercise would be walking, jogging, running, swimming, cycling. And then we have resistance exercises. These also reduce the inflammation in the liver and improve the sensitivity of the body to metabolize and absorb insulin. This improves our metabolic parameters. Resistance exercises would be weightlifting, dumbbells, free lifts, things like that. So, what are the lifestyle tips to tackle fatty liver? First of all, regular medical checkups so that we are sure whether we have fatty liver or not. We should eat small and frequent meals, one small meal every 3 to 4 hours. lowering our sugar intake, getting enough vitamins and minerals, getting enough sleep, and developing an exercise routine which is easy to do, which we enjoy doing, which we can do on a daily basis, and then sticking to it. When we talk of the medicines of fatty liver, it is pretty simple. The molecules currently used are pioglitazone, which is used for NASH with or without fibrosis, usually in diabetic patients, but can be used in non-diabetic patients also. Saroglitazar, which is an Indian molecule, which is used in NASH with or without fibrosis in both diabetic and non-diabetics for a minimum of 1 year, and vitamin E, which is prescribed in NASH with or without fibrosis in diabetics and non-diabetics alike for a minimum of 2 years. How do we prevent fatty liver disease? We limit our intake of saturated fats, we eat a balanced diet, we decrease our carbohydrates, like we discussed, rice, potatoes, etc. We maintain a healthy weight. Quitting smoking is very important, as is exercising regularly, limiting or entirely avoiding alcohol, and taking medicines as prescribed by a doctor. So let us pledge to not be silent anymore about this silent disease. And our liver can still be at risk even if we don't consume alcohol. People who are teetotalers can still have a fatty liver, can still have a chance of progressing to cirrhosis. We should regularly get checked up. And if you have a fatty liver, get treated for it on time. Thank you.
So much, sir, for this wonderful talk. Sir, with your permission, can we move to question answer part?
Please.
Yeah. So, sir, how common MASLD and MASH in Indian population?
So these are extremely common. I would say that around 1 in 4 people of the average Indian population does have a fatty liver or advanced fatty liver disease. Almost all diabetics that we see have some degree of fatty liver, and most people with obesity or those who are overweight who come into our OPD also have fatty liver. So it is far, far more common than we originally thought.
Okay. So, sir, can we say MASLD and MASH be age specific disease?
I couldn't hear you.
Can we say MASLD and MASH be age specific?
No, there is no real age specificity between the two. Yes, it is more common in those above the age of 40, but it is not so that younger people cannot have a fatty liver. We get a lot of people in their teenage, in their adolescence years, in their early 20s who have advanced fat in the liver, who have a lot of fat in their liver. So the earlier dictum that fatty liver occurs only in the elderly or only in those above the age of 40, 50 is not true. A lot of young people also do get a fatty liver.
So, what kind of exercise will you recommend to fatty liver disease patient?
So, like we discussed, the two types of exercises that we do are aerobic and resistance exercises. For most people, we recommend exercising 5 to 6 days a week, 40 minutes each day. And out of these 5 to 6 days, 2 days should be spent with resistance exercises. So, if you're jogging 6 days a week, in 2 of these days, you add dumbbells, you add free weights, you add some push ups, pull ups. And on the other 4 days, you do simple aerobic, that is cardio exercises.
Sir, what is your message to the people watching this live who have been told that they have fatty liver?
Right. So the message is very simple. Fatty liver is far more prevalent than we thought. It is easy to prevent, easy to diagnose, and easy to treat. Provided we understand what fatty liver is, we understand how dangerous it can be, and we take the right steps at the right time to prevent and treat it.
All right. Now, on behalf of Nash 24 by 7, I extend my sincere thanks to Dr. Dhruv for his enlightening and engaging talk on myself. I also want to express my appreciation to our audience for their participation. Stay connected with Nash 24 by 7 on Facebook page for upcoming updates and events. Remember, your health is our priority, so take care, stay well. Thank you so much, sir, for joining us today. Thank
Thank
you,
you, ma'am.
everyone.